So hi everyone. Today we are discussing about steps of ECG reading. Steps of ECG reading. So we start to read the ECG from rhythm. Look for the rhythm in the ECG. That is the first step. Whether it is regular or irregular. An ECG strip is called regular if it has equal RR intervals. And if it is unequal, it is called irregular. Okay. The second step is rate calculation. So, for a regular rhythm, we have two methods to calculate the rate. So, the heart rate is equal to 300 divided by number of large squares between two consecutive R waves, or it's also equal to 1500 divided by number of small squares between two consecutive R waves. We can calculate the heart rate using this formula. Okay, for a regular rhythm. But for an irregular rhythm, we have another formula. Just count the number of QRS complexes in 6 seconds. Okay, count number of QRS complex in 6 seconds. So what is this 6 second? It is equal to 30 big boxes, 30 large boxes. Okay, so we will get number of QRS complex in 6 seconds. What is heart rate? Number of QRS complex in 60 seconds. So multiply it with 10. It will give you the heart rate. Okay, this formula is used for an irregular complex. Now, third step is axis. For determining the axis, there are different methods, but the most efficient way to estimate the axis is by looking at lead 1 and lead AVF. Okay, lead 1 and lead AVF, because these leads are in their spatial orientation, these leads are perpendicular to each other. This is lead 1 and this is lead AVF, and they are perpendicular. Okay, and look for the QRS complex in these leads. Okay, if it is positive in both leads, their vector will be like this. If it is positive in lead 1 and it is positive in lead AVF, the resultant vector will be here, and it is a normal axis. Normal axis. Okay. What if it is like this? This is your AVF and this is your lead 1. And if it is positive in AVF, it is positive in AVF. Okay. And negative in lead 1, like this. Okay. It is negative in lead 1. If this is like in lead 1, you have an ECG like this, and in AVF it is like this only. Here in lead 1 it is like this, and in AVF it is positive. So the resultant vector will be like this, and it is called right axis deviation. Okay, it is right axis deviation. And again, this is your 1 and AVF, and suppose in lead 1 it is positive, and in AVF it is negative. So it will be like this. Here it is positive, and in AVF it is opposite direction, and the resultant vector will be like this, and this is called left axis deviation. Okay, and finally, if it is both are negative in AVF and also lead 1, the ECG is like this. It's a deep Q wave, and in AVF also there is a deep Q wave like this. So the resultant vector will be like this, and it is called extreme axis deviation. So this is our normal axis. Normal axis both are positive. Okay, and when in lead 1 it is negative, and in AVF it is positive, it is called a right axis deviation. When in lead 1 it is positive and AVF it is negative, it is called left axis deviation. And if both are negative, it is called extreme axis deviation. This is how we calculate the axis of the ECG. Okay, so we are moving to the first wave. So the fourth step is, after looking in the rhythm, rate and axis, the fourth step is commenting about P wave. P wave. P wave is the first positive deflection on the ECG. First positive deflection in the ECG. And the normal P wave is 2.5 mm, that is 2.5 small squares in duration and height. The duration and height, it will be 2.5 mm, and the first one third is corresponds to right atrial activation, the first 1/3 of P wave. Okay, and the last 1/3 corresponds to left atrial activation. Okay, we know that P wave corresponds to the atrial systole. So the first 1/3 is right atrial activation, and the last 1/3 is left atrial activation, and the middle third is combination of two. Combination of two. Okay, so moving on to the abnormalities in P wave. Abnormalities in P wave morphology. Abnormalities. So the first morphological abnormality is like this, that is increased duration of P wave. Increased duration of P wave, and it is called P mitral. P mitral, and it is seen in P mitral is seen in left atrial enlargement. Left atrial enlargement. Next is like this. It is the increase in height of P wave, increase in voltage of P wave, increased voltage or height of P wave, and it is called P pulmonale. P pulmonale, and seen in right atrial enlargement, seen in right atrial enlargement. Okay, and the third condition, it is called inverted P wave. Okay, inverted P wave. In case of inverted P wave, it indicates non-sinus origin of P wave. That is non-sinus origin. P wave is not originating from SA node, instead originating from either AV node or some other part of atria. Okay, so how to differentiate whether it is originated from AV node or some other part of atria? Look for the PR interval. It can be originated from AV node or atria other than SA node. So look for the PR interval. If PR interval is less than 120 millisecond, it is originated from AV node. If PR interval is more than 120 millisecond, it is originated from atria other than a site SA node. Okay, because if it is originating from AV node, there is no PR interval indicates that AV nodal delay. Okay, so if it is originating from AV node, there will be a short AV nodal delay, that is less than 120 milliseconds. This is how we differentiate the inverted P wave, whether it is AV nodal or atrial. Okay, and the last abnormality in P wave is variable morphologies. That is, if more than or equal to 3 different P wave morphologies are seen, P wave morphologies, then it is called multifocal atrial tachycardia. Multifocal atrial tachycardia. Okay, that is all about the P wave. So we have seen the rhythm, rate, axis and P wave. So the next thing in ECG reading is, the fifth thing is PR interval. We are already discussed about the normal PR interval and how to calculate PR interval all in the previous video. So now in this video we are just talking about the abnormalities in PR interval. So first one is prolonged PR interval. Prolonged PR interval. Prolonged, which means the PR interval is more than 200 milliseconds. It is seen in heart block. The different types of heart block are first degree heart block, okay, then second degree and third degree. So in first degree there is prolonged but fixed PR interval. Okay, prolonged ആയിരിക്കും but fixed PR interval, like this. Okay, and the next ECG will be like this. The PR interval will be same for all waves. Okay, that is first degree. In the second degree, again two types. Second degree heart block, again two types. Mobitz type 1. Mobitz type 1. In Mobitz type 1, there is progressive prolongation of PR interval followed by a missed beat. Okay, initially the PR interval is like this, then in the next wave it is increased, and in the other wave it is further increased, and after that there will be a non-conducted P wave. Okay, that's about Mobitz type 1. In Mobitz type 2, again the PR interval is fixed, but there will be intermittent non-conducted P waves. You can see the PR interval is fixed, but there will be intermittent non-conducted P waves. The PR interval is fixed, same, all are same. Okay, the last type of heart block is third degree heart block, or also called complete heart block. So there is no association between atria and ventricle, complete AV dissociation. Atria has its own rhythm and ventricle has got its own rhythm. So it will be like this. Okay, but one thing is there, PP interval will be same and RR interval will be same. The gap between two P waves, here is also will be the one P wave, will be same. Again, the RR intervals, you can expect another R wave at an equidistant from between, as the distance between these two R waves. This will be same. Okay, that is third degree heart block. So that's about the PR prolongation. Now shortening of PR interval, that is less than 120 millisecond. It is seen in two conditions. One is WPW and LGL, long ganglion syndrome, and WPW syndrome. These are the two conditions where you can expect a shortened PR interval. And also in one more condition that we have already discussed, if the beat is originating from AV node as a inverted P wave, we can see expect a less than 120 milliseconds of PR interval. So in the junctional rhythm also there will be a shortened PR interval. Now after the PR interval we have Q waves. So a Q wave is any negative deflection preceding an R wave. Okay, Q wave is defined like that. It is a negative deflection that precedes a R wave. Okay, and a Q wave is considered to be pathological if it is either more than 40 millisecond wide or more than 2 mm deep or more than 25% of depth of QRS complex. If it is satisfying any of these, it is called a pathological Q wave, and a pathological Q wave indicates current or prior myocardial infarction. Okay, that's about Q wave. Then step number 7 is commenting about QRS complex. A normal QRS width. Normal width of QRS complex is 70 to 100 milliseconds. A narrow QRS are supraventricular in origin. Supraventricular. If a beat is originating at a supraventricular level, that is either from atria or SA node, AV node, it is called supraventricular. And you can expect a broad QRS. Broad QRS means QRS duration more than 120 millisecond. If it is ventricular in origin, ventricular, or you can also expect a broad QRS in aberrant conduction. Aberrant conduction. Okay. So already discussed, the supraventricular sites are SA node, atria, and AV node. You can expect a narrow QRS complex and broad QRS complex either in ventricular origin or in aberrant conductions. So what are these aberrant conductions? Aberrant conductions are either LBBB or right bundle branch block. It is an aberrant conduction. In case of hyperkalemia, pre-excitations, hypothermia, and ventricular pacing. These are the aberrant conductions. Okay. So the 8th part is QT interval. Already discussed in previous video about the duration, normal duration, Besset's formula and all. And now we are discussing the abnormalities. So what are the conditions causing prolonged QT interval? You can see in hypokalemia, magnesemia, calcemia, in hypothermia, myocardial infarction, and congenital QT syndrome. These are the common conditions associated with prolonged QT. Now, shortened QT or short QT or short corrected QT is seen in hypercalcemia, congenital short QT syndrome, congenital short QT syndrome, and digoxin effect. Say effect of digoxin, there will be short QT. Now the 9th part of ECG reading is commenting about ST segment. So what are the causes of ST elevation? The first answer will be nothing but myocardial ischemia. So the other causes include acute pericarditis, benign early repolarization, left bundle branch block, left ventricular hypertrophy, Brugada syndrome, raised ICP, Takotsubo cardiomyopathy, and in Prince metal angina also. So these are the few causes of ST elevation. Now the cause of ST depression. ST depression. It is seen in again NSTEMI, non-ST elevation myocardial ischemia, as a reciprocal change. Reciprocal change in STEMI. Okay, it is also seen as a reciprocal change in STEMI. Digoxin effect. Digoxin can cause ST depression. Hypokalemia. Hypokalemia. Supraventricular tachycardia, SVT, there will be ST depressions. Again, right bundle branch block, right ventricular hypertrophy, and ventricular pacing. Ventricular pacing. These are the cause of ST depression. The last part of ECG reading is commenting about the last wave, that is our T wave. So the T wave will be upright in all leads, normally upright in all leads except in AVR and V1. In AVR and V1 it will be negative normally. So talking about the abnormalities, there are 5 different kind of abnormalities in T wave. So first one is peaked T wave. Peaked T wave. It is seen in hyperkalemia. Hyperkalemia. Second one is hyperacute T wave. Hyperacute T wave. It is an early sign of STEMI. So when you see a peaked T wave in a CKD patient, you can consider it as a hyperkalemia. But if a patient presented with chest pain and you have taken an ECG, it shows a peaked T wave, it is more likely an early sign of STEMI. So based on the clinical background, we can decide whether it is a peaked or hyperacute T wave. Okay. And inverted T waves. Inverted T wave. The third morphological abnormality is inverted T wave. It is seen in again myocardial ischemia in NSTEMI, including Welland syndrome. In Welland syndrome also there will be a deeply inverted T waves in lead V1 and V2. Again bundle branch block, ventricular hypertrophy, that is strain pattern. In strain pattern there will be inverted T wave, and in also raised ICP there will be global T inversions. Okay, but occasionally the T inversion in lead 3 alone may be normal, may be a normal variant. Okay, and again a new T inversion in comparison with the old ECG, a new T inversion is always abnormal. Okay, it is always abnormal. And the pathological T wave inversions, that is like in the strain pattern, there will be T inversion that is not pathological, but in MI the T inversion is pathological. So the pathological T inversion is usually symmetric and deep. Okay, pathologic T inversion are usually deep and symmetric like this. It will be deep and symmetric. And the fourth morphological abnormality is biphasic T wave. It is seen in again myocardial ischemia and hypokalemia. And the last abnormality is flattened T wave. Flattened T wave again also seen in myocardial ischemia or hypokalemia. So this is how you have to read an ECG, starting from the rhythm, rate, axis, then comment about the individual waves and segments in ECG in order. Okay, thank you.